Hello, everyone. This is lecture 4.1, and this is part 1 of this screencast. So this week, due by October 2nd, we've got discussion topic number 2 and your week 4 homework. So looking at discussion number 2, for this discussion, you will identify one common injury or disease that you evaluate and treat in your place of employment. If you are not currently treating patients, then think about a patient you have worked with in the past. Next, you will report 1 to 2 known risk factors for the selected injury or disease. It's important to highlight that some risk factors that are thought to be related to disease or injury have not been assessed prospectively. You will then assess the literature for studies that have supported or refuted the risk factor. And I'd like you to present 1 to 2 references in your post. Now, while you're at things, take a look at what your classmates are writing. Would like you to do a response post due by October 5th. You're going to review the reported risk factors from 2 classmates. Review the literature for additional studies that support or refute the risk factor. You will provide a reference to each classmate and the keywords you utilize to perform your literature search. Okay, let's talk about risk. Risk is the probability of some untoward event. In healthcare, we are constantly dealing with probabilities. We want to know, are the things that we are doing going to increase the risk of disease in somebody? We want to know if the way that somebody participates in sport, is that going to increase their risk of injury? We want to know, are we doing things that help to reduce the risk of having to come back into the hospital? Now, I don't have the video playing here, but you obviously see somebody who's balancing themselves on 2 cars. And if you were to run the video, you would see that the cars are moving pretty fast, and then all of a sudden the individual gets hit by a pole right in his midsection. Individual is doing risky behavior and ultimately pays the price. Our goal with epidemiologic research is to identify those risk factors that increases somebody's risk of disease or injury in order to do subsequent research to see if we can intervene to reduce that risk of injury or disease. So in studies of risk, we're going to look at estimating risk by observing relationships between exposure to possible risk factors and subsequent incidence of disease. Let's talk about prospective studies. The most powerful way to determine whether exposure to a potential risk factor results in increased risk of disease is to perform a study in which the investigator determines who is exposed. One group is exposed to the purported risk factor, or they have that risk factor, and the other group is not exposed to it, or they don't possess that risk factor. We'll see an example of a prospective cohort study coming up. There are times, though, when prospective cohort studies, even though they would be considered the gold standard, they are not possible or ethical. For example, for ethical reasons, we could not do the following types of studies. We could not have an experimental group gain a lot of weight and then follow them over time to see if they develop cardiovascular disease. We couldn't require an experimental group to initiate a smoking habit. And we could not require those in an experimental group to purposefully perform risky driving behaviors. Why? Well, in the first case, for having people gain weight, it would be unethical to impose possible risk factors on a population of healthy people. Same thing with smoking. If we're assuming or if we believe that that can increase the risk of disease already, it would not be ethical for us to require that. Also, it's not possible because many people would be against having their behaviors or diets drastically changed. If you were part of a study and you had a very active lifestyle and a diet that you observed, if you were told to change your diet, adopt one that consisted of more energy dense food and less fruits and vegetables, less whole grains, you probably would not stick with that study. Also, if you did not like to smoke, you would not want to be forced to smoke. Now, the study types that were described in the prior slide would potentially need to be conducted for years. And it becomes very difficult for most of us to conduct studies like these. Why? Well, to be able to conduct a prospective cohort study looking at the onset of chronic health conditions, you would need lots of money, lots of time. You would need to have a team to support that. It would have to be something monumental like the Framingham study. So, we talked previously about observational studies. That's what we're talking about in this lecture. Observational studies are ones in which a researcher gathers data by observing and not intervening. Most studies of risk are cohort studies or case control studies. A cohort is a group of people who have something in common when they are first assembled and who are observed for a period of time. Observations of a cohort should fulfill three criteria in order to provide sound information regarding the risk of disease or injury. First, they do not have the disease or the outcome of interest in question at the time they are assembled. That is true for both the prospective cohort as well as the retrospective cohort. When they're assembled for a retrospective cohort, they were initially assembled in the past. Of course, you're looking at them in the present, but when they were first available for initiating surveillance, they were disease-free or injury-free. Cohorts should be observed over a meaningful period of time in the natural history of the disease in question. And all members of the cohort should be observed over the full period of follow-up, or methods should be used to account for dropouts. So let's look at a prospective cohort study in a little bit more detail. It's a study in which a subgroup of a population that is exposed to a risk factor, or if they already possess that risk factor, for example, think genetics, and another subgroup that is unexposed to the risk factor or don't possess that risk factor, they are followed forward in time and the incidence rate of the disease in each group is determined. So again, when they are assembled, they are initially disease-free. This type of study provides incidence data. You're able to assess the relative risk accurately. So this is the best estimate of the risk association of a disease or disorder. You're able to assess the temporal order more accurately. Usually a large population is followed over several years. Now, that would be necessary for most cases looking at a disease. If you are somebody who works with musculoskeletal injuries, You may be able to do this in a shorter period of time. However, you may still need to get a large population. For example, go back a few weeks, listen to my volleyball recording talking about what I did with volleyball athletes. I had 7 or 8 teams, and I was able to get a majority of those teams in a 1-year time period. I also had some data on my other team, George Fox, for the 2 prior years, so I was able to incorporate that data also. So that was done in a relatively short period of time. Usually, more common diseases or disorders or outcomes are assessed. For example, computer use and the risk of carpal tunnel syndrome. Or you could do something like low back pain in construction workers during the building of a new apartment complex, or sports injuries occurring during the 2023-2024 sports season. So here is a great way to think about what a prospective cohort study would look like. You have your population without disease or injury, and they are assembled in the present. And then you're going to dichotomize them or categorize them into one of 2 groups. Those who are exposed, that is our at-risk group, the group that we think or we hypothesize is at greater risk of injury. And then we've got the not exposed group, or the group who we think is at a lesser risk of injury, also known as our reference group. Then we follow them forward into the future, and we look to see what are the proportions of disease or no disease, or injury or no injury, etc., in each group. Here's an example from the world of sports medicine. This is a made-up example, but let's say we had 200 high school female basketball players without ACL injury. And they're assembled at the start of the season. They all do not have ACL injury history. We did some testing, and we did isokinetic testing to find that 100 players had an abnormal quadricep to hamstring strength ratio, whereas 100 players had a normal presentation. And then we followed them over the course of the basketball season from October of 2014 to March of 2015. And we found that there were 50% of those with an abnormal preseason ratio that went on to have an injury, whereas only 20% experienced an injury in the normal group. Now, a classic cohort study example is the Framingham study. This was started in 1949, and the goal was to look for risk factors associated with coronary heart disease. They followed 5,127 people who at baseline were free of coronary heart disease, and they followed them for 30 years. And actually, they've been following people for many years. They're now on to, I think, the 3rd or 4th generation of individuals, and they continue to follow this population within Massachusetts to look to see what increases the risk of coronary artery disease or heart disease. And some of the things that they found included elevated blood pressure, high serum cholesterol, cigarette smoking, glucose intolerance, and left ventricular hypertrophy. Now, cohort studies can be accomplished in one of 2 ways. There can be the prospective way, where the cohort's assembled in the present and followed into the future. That's the Framingham study example. It's also the way that I've done many things where I have looked at Division III, Division II, NAIA athletes, tested them in the preseason, and then observed them over the course of their season for injury. There is also the retrospective or historical cohort. And so what's going on here is you've got individuals who were assembled at one time and they were free from injury or disease at that time, but they were assembled in the past and you don't really know anything about potential risk factors for them. What you know is what the injuries or the disease presentation is like in the present. Now, if you have access to a lot of retrospective data, I envy you because it's a great opportunity for you to do really impressive studies. Just kind of a quick aside, one time I was presenting for an American College of Sports Medicine poster presentation. It was a thematic poster presentation where they had like 6 or 7 of us in a room. Our posters were up. We were able to talk about our study for about 5 minutes while people walked around and looked at the poster. Well, my particular study had about 80 some subjects in it. It was a prospective cohort study. The other studies, some of them had 5,000, 10,000 subjects in them. And there's no way that these individuals had collected that information prospectively. They were able to access these large data sets, usually from computerized medical databases. So historical or retrospective cohort studies, again, utilize those computerized medical databases and population registries. What are the advantages of a retrospective cohort study? Well, they take less time. Why? Because usually somebody has done all the work for you. They've collected information for you. And so that's all been done in the past. You just have to look at the data, enter it into your statistical software package, and crunch things. They're less expensive because the data is all done. Whereas when I've done prospective cohort studies, we have reimbursed athletes to come to our facility, upwards of $100 per athlete. And so these studies are much easier to perform. Here's the disadvantage, though. You cannot undertake a study of factors that were not recorded in the database. And so it's possible that a potential risk factor is missed. Also, there's the possibility of bias if the data was not collected in a standardized manner. Right? If you do a prospective cohort study, you're probably doing a reliability study prior to things to make sure that how you're measuring is done consistently, that you're reliable with your measurements. You may not have that, or that may not have been done when somebody's collecting data in that type of manner. So here's what a retrospective study looks like. In the present, and you don't even know this yet, you don't know which group people are in. You just know people have disease or no disease. So in the present, there are people that have the disease or injury, and they also don't have the disease or injury. So what you do is you go back in time when people were first assembled without the disease or injury, and then you can look at whatever information you have available to you to put people into the exposed and not exposed groups. Remember, again, this is the at-risk group. The group you've hypothesized are at risk, and this is the not exposed group. So here's an example. You work at a skilled nursing facility, and you recognize lately there have been a lot of falls. You don't know this information yet. You don't know the percentages. What you do know is that when people are admitted to your skilled nursing facility, you do a test to look at ankle stability. And you found that 100 elderly women have poor ankle stability based upon the test that you performed, and 100 had good ankle stability. So you see, you've categorized them into one of two groups. Now, based upon how you categorize them, you can see that 60% of those with poor ankle stability had a fall, where only 10% had a fall in the other group. So, how do you know if a study is a retrospective cohort study? Well, usually it says in the title. This is a great example here. Epidemiology of bone stress injuries in Australian high-performance athletes, a retrospective cohort study. If it doesn't say right away in the title, probably is going to say in the methods. So this is another example here where they're describing the methodology to access the record. Sometimes, though, it's not readily observed. And I bring this one up because in this particular paper, for those of you who are physical therapists and athletic trainers, this was a really influential paper published in 2007 in the North American Journal of Sports Physical Therapy. So what it was is a study looking at the functional movement screen. So for those of you who aren't familiar, it's a battery of tests that ranks people on their performance. They're given a 3, 2, 1, or 0. And what this particular study reported is that individuals with a 14 or below on the test out of 21, they were at an 11 times greater risk of injury. So, was it prospective? Was it retrospective? Doesn't say in the abstract either. You've got to dive into the article to find out that the authors here were not the individuals who were collecting the data. It was collected by, if I remember correctly, a strength and conditioning professional for the football team. So we have got no indication as to how reliable that professional was with their ability to score the FMS. What's interesting is the vast majority of papers that have looked at the functional movement screen as a predictor of injury since this paper has shown that there is no relationship. Okay, let's stop here. And when you're ready, start up with part number 2 or part B.